morning. Welcome back to Open Med School. Dr. Andrews, Professor of Medicine, Consultant Neurologist. Last time we have discussed about the normal values in ABG. So today I'll be discussing an approach to ABG. There are different ways. From a clinician's point of view, a 5-step approach is what I am going to discuss. So first step, before looking into the ABG, confirm that the ABG belongs to a particular patient and what is the clinical status of that patient. That is very important to remember this point. How is the patient? Many times you may get an idea regarding what is to be expected or what is likely to get in the patient by knowing the clinical status. This will be discussed in detail at the last part of the session on interpretation of the findings in the clinical context. Step 2 is identifying whether the patient is hypoxemic or not. This is the most important part, because whatever be the ABG, the patient is having significant hypoxemia, unless you correct it, patient is going to die. That is the second step, is identifying whether the patient is hypoxemic. Step 3 is the patient acidemic or alkalemic? That is by looking into the pH. So here we'll be looking at the PaO₂ mainly. And step 4 is what is the carbon dioxide? So you are looking at the respiratory component. And next step is what is the bicarbonate, the base excess, or you are looking at the SaO₃, that is the component by the kidney. And in the fifth group, that is the bicarbonate, or when the patient is found to have acidosis, there are different paths by which we will be going into the details of the abnormality. So this is the basic format you have to follow in any patient. Today we will be discussing about the analysis of how the oxygen or oxygenation is assessed. So oxygenation is assessed by looking at the PaO₂, second is the SaO₂, and third is the SpO₂. The total oxygen content can be calculated by the SaO₂. That is beyond the scope of our discussion. And in order to know whether the lung is functioning, there is something called AA gradient. AA gradient stands for the alveolar arterial gradient. So look at this ABG, you can see that the first is will be looking at the PaO₂. So here the PaO₂ is 113. So what is a normal PaO₂? The normal PaO₂ should be more than 75. 75 to 100 in room air. This is a very important point to be kept in mind. That is, in room air, the PaO₂ is 75 to 100. Think that the patient is on a face mask like this with oxygen. A normal PaO₂ is definitely abnormal. That is what you should look into the clinical context of the patient. So oxygenation, as I already mentioned, it is the PaO₂ is the most important measure. The SaO₂ is saturation of oxygen calculated from the PaO₂. So remember, it is a calculated value. You should remember the oxygen dissociation curve, which is a sigmoid shaped curve. When the PaO₂ is 60, the SaO₂ is around 90%. When the PaO₂ is less than 60, the severe hypoxemia. So that is why we try to maintain the PaO₂. So what is the difference between PaO₂, SaO₂ and SpO₂? SaO₂ is the saturation of oxygen calculated by the ABG machine from the PaO₂. PaO₂ is the partial pressure of oxygen in the blood. SpO₂ is the using the pulse oximeter from the periphery, that is the SpO₂. So what the SaO₂ and SpO₂ are related. So what is SaO₂? And what is PaO₂? So in the blood, oxygen is transported as dissolved oxygen and also carried by the RBCs in the hemoglobin. The dissolved oxygen determines the PaO₂. So PaO₂ is the dissolved oxygen, the pressure exerted by that gas. It has to do nothing with the hemoglobin or SpO₂. So what is SpO₂? SpO₂ is the measured by, as already mentioned, by the pulse oximeter. It is the percentage saturation of the hemoglobin with oxygen. We know that hemoglobin contains 4 iron molecules. If all are saturated, you can say 100% saturation. So in the RBCs, depending upon the oxygen saturation of the RBC hemoglobin, that is the SpO₂. SaO₂ is the same saturation of oxygen calculated using the oxygen dissociation curve. So now I think we have understood what is PaO₂, SpO₂ and SaO₂. Sometimes there can be significant difference between PaO₂ and SpO₂. That is, pulse oximetry shows a very high value, around 95 or a normal value, whereas the partial pressure of oxygen by the blood gas analyzer is low. And if the patient is looking normal, it indicates a venous sample. So that is the importance of looking at the SpO₂ along with the PaO₂. In some conditions, there can be difference between the SpO₂ and SaO₂. That is saturation calculated using the ABG machine and the pulse oximeter. Typical example is the carboxyhemoglobin methemoglobinemia. So there can be a dissociation. It is called the saturation gap. The alveolar arterial gradient we will discuss in another session. So I already mentioned the PaO₂ less than 75 is hypoxia, less than 60 is significant. At the 60, the SaO₂ is around 90%. This is basically what you should remember. Now, when you are giving patient oxygen, I have already said shown a patient with on oxygen. What will be the oxygen concentration in the inspired air and what will be the PaO₂? We'll just have a say when 1 liter is given, the percentage of oxygen in the inspired air, it is otherwise called FiO₂. In the atmospheric air, the FiO₂ is 21%. For ease of calculation, take it as 20%. When 1 liter of oxygen is given through nasal cannula, it is approximately 4% increase. So it becomes 24. 2 liter oxygen by nasal cannula will be 2 into 4. So it will plus 20, it becomes 28. 3 liter, 3 into 4, 12. So it will be 32. So this is how you approximately identify the percentage of oxygen in the inspired air. This is important for calculation of the PaO₂ FiO₂ ratio, especially for identifying the ARDS. So what is the relationship between the FiO₂ and PaO₂? That is, when you are giving 1 liter of oxygen in a normal lung, what must be the PaO₂? So atmospheric air FiO₂ is 20, the PaO₂ is 100. So it's approximately multiplication by 5. So somebody has got FiO₂ 40%, 40 into 5, it will be around 200. It is not exact value, it is an approximate value. So this is how you calculate or you will try to find out what must be the PaO₂ when the inspired oxygen FiO₂ is high, or you are supplementing patient oxygen. Now look at what are the ways of supplementation of oxygen. One is a simple face mask. Here you can make the FiO₂ 40 to 60% when the flow is around 15 liter per minute. Again, remember that depends upon the patient's type of breathing, fitness of the mask, etc. This may change. Then comes the reservoir mask, or otherwise called the non-rebreather mask. You can give up to 60 to 90% of FiO₂ using this. And then comes the Venturi mask. The percentage of oxygen that can be given is written on the mask. It can be 24, 28, 35, 40. 24, 28, 35, 40. So Venturi mask is useful especially when patient has got a hypercapnia. The details of use will be discussed in separate sessions. We have already mentioned when there is hypoxemia, the patient has developed a respiratory failure. And respiratory failure you divide into type 1 and type 2. Type 1 is hypoxic, only hypoxemia, but the carbon dioxide is normal, that is less than 45. Type 2 means both, oxygen is less, carbon dioxide is high. So here it is hypoxic plus hypercapnic. So that is how you remember it. So type 1 respiratory failure, as mentioned, the PaO₂ is more than 60 and the normocapnia is less than 45. What is a classical condition that produces type 1 respiratory failure? It's pneumonia. It can occur in whenever there is ventilation perfusion mismatch, like pulmonary edema, pulmonary embolism. You can get a type 1. So there is a ventilation perfusion mismatch. In pulmonary edema, perfusion is there is a mismatch. Some of the areas are consolidated, so there is no ventilation. So ventilation perfusion mismatch. Type 2 is both hypoxemic plus hypercapnic. Bicarbonate is more than 45, oxygen is less than 60, PaO₂ is less than 60. The classical condition that produces type 2 respiratory failure is COPD, chronic obstructive pulmonary disease. We can get in conditions like decreased respiratory drive, somebody with a morphine poisoning, a fracture of the rib that produces changes in the breathing pattern. So remember COPD as the typical example of a type 2 respiratory failure. So today we have discussed about the steps, and the first two steps, the clinical status of the patient we have to look for. Second is identify whether the patient is having hypoxia or hypoxemic, that is respiratory failure. If it is respiratory failure, identify whether it is type 1 respiratory failure or type 2 respiratory failure. We have also discussed the importance of looking at the patient's clinical status, whether the patient is being given oxygen, and we have learned how to identify the percentage of oxygen when oxygen is supplemented using nasal cannula or mask, and also how to calculate the expected PaO₂ with a particular percentage of FiO₂. The next session we will be discussing on step 3, that is looking at the pH, is the patient is acidemic or alkalemic.